Well, thanks, Mike. And first of all, as having the privilege to be the chair of the meeting this year, thank you for coming to the meeting, and importantly, thank you for coming to this session. As you'll hopefully hear, we think this is of tremendous value, particularly in the times that we are facing these days. I have no disclosures. So let me just set the stage here for the afternoon. For those of you who had a chance to be here this morning, we had a number of talks that were really strategic in value. We heard a little bit about the concept of volume versus value. We heard about the real world of value, what's been going on for the last 40 years or so, actually here in Maryland, with fixed payment schemes. We got the basics on alternative payment models and sort of what that's all about. And then Linda Gillum gave a beautiful lecture on sort of how those global concepts begin to tie into the service line. Following my talk, Dr. Candaria is going to talk really about operational metrics, really getting into the weeds. Dr. Weissman's going to talk about echo and care bundles, so I think how to frame this a little bit more. And then Dr. Main is going to talk about reimbursement. So what I want to do is really be that bridge between strategy and tactics and hopefully provide a framework for how to think about this in this rapidly changing payer landscape. So really three parts to the talk. The first part, what's the burning platform here? Why are we talking about this? Why is there so much energy about this? And the simple fact that we have to take home with us is that Medicare has a math problem, okay? If you look at the graphic here in 1970, you can see those above the line represented by a triangle were 20.4 million. If you were 85 or above, you were a rounding error, okay, back then. If you look at the bottom of the graph, you can see in the salmon color, those are the baby boomers, okay? Now look where we are in 2017, okay? That wave has hit the shore a couple of years ago. We have 58 million. That's the same triangle, just superimposed. That's not an optical illusion. You can see that over time that women live longer than men, but you can see what the issue is here just in terms of the sheer number of beneficiaries that we have to manage. If you look at that in terms of dollars and cents, in terms of spend, we're going to spend about $560 billion on this, and you can see from an actuarial perspective, right, unless we bend the cost curve in terms of spending, we know what the numbers are going to be actuarially in terms of the number of beneficiaries. You can see what we're going to be spending over the course of the next 8 years. Okay, what percentage that comprises of the budget is up for grabs depending on how much we grow as an economy. But the absolute numbers are fairly predictable. This is what makes things maybe even a little bit worse. On the left side, you can see the rise in the beneficiaries, which I just showed you. But here's a statistic that we're not really talking about. Back in 1970, we had 4.6 workers funding Medicare for every beneficiary. This is dropping down to 2.3. Okay, and again, this is just math. There's nothing we can do about this. This is reality. So how does that begin to play out? Well, if you take a look at making no changes, the curve, the dotted line, is the spend curve. If you look at what has been refereed as sort of the bending of the cost curve with existing legislation, it flattens in 2030. It goes up, but it flattens in 2030. So anything that's on the table today, repeal, replace, any of these things are going to have to match what we're seeing on the projections that are here. This is why there's such bipartisan support for MACRA in Congress. Everything that we're hearing, although it's complex and confusing with legislation, is really about the Medicare aspects and insurance coverage with respect to ACA. It's not about MACRA, it's not about value. That is embedded and that's here to stay. And this is also playing out in the private markets as well. So Medicare Advantage, the portion of Medicare that's a per member per month, that's going to increase to 40% by 2025. Medicaid, 70% will be tied to value. And then ACOs, about 85% of the country is proximate to an ACO market, and ACOs are on a pace to comprise about 64% of the market. So this fee for service, just put your head down, do the service, do the billing, and come in, is not going to be the reality over the coming years. So we've got to get prepared for that and have a strategy. And one of my favorite quotes, this is from science fiction writer William Gibson, who, by the way, coined the term cyberspace, little factoid. But this great quote, "The future is already here, it's just not very evenly distributed." The fact about value and so forth, we heard about it in Maryland. It's happening over the country. I'm from the Southeast. We don't really feel it yet, but your market may already be, 5 years ahead of mine in terms of what your already experience has been. So what's a strategy? How do we begin to tackle this? What are the sort of foundational principles? And this is where I just want to walk through a very quick value checklist. And when I talk about value, simply what we're talking about is the quality of what you do divided by the resources you commit to doing it. So it's a very simple equation, and we have to look at both the numerator and the denominator. And if I can get my slides to keep going. Here we go. So if you are in a leadership position in your lab, if you're an administrator, if you have any influence in your organization to other administrators, these 6 qualities ought to be able to roll off the tip of your tongue. Okay? This is what has been defined by the Institute of Medicine. When we talk about quality, it's one of those things, well, I know it when I see it. Well, you can actually break it down into its constituent parts, and we will do that for echo in just a minute. But when we talk about quality care, we're talking about care that first and foremost is safe, needs to be effective, needs to be efficient, and then also we need to be able to deliver it in a timely way. We want to do it in a way that is patient-centered, and we want to be equitable in how it is distributed. Those are the elements that have been nationally defined in terms of quality care. So where does ECHO stack up? And we'll talk a little bit more about this later on in the talk, but if we just go through this pretty quickly, and I think all of us who are, here at the meeting, and maybe some of the administrative folks who are new to this may not be as well versed, but we know it's safe. It's non-invasive, no biological risk. Is it effective? Well, the whole scientific sessions are about the effectiveness of ECHO, but I think we would agree that the degree of information, the sophistication of the information that we get is just ever increasing with respect to our modality. Is it efficient? We'll talk about that in a minute. Timely? Yeah, we can do this 7 days a week. We can do it portably. We can go to the patient's room. We can do stat studies. We can do things that some of the other modalities just can't. Equitable? Yeah, I mean, we can take it to, any setting you want. We can do population screening in indigent areas. We can utilize this technology. And is it patient-centric? Of course. It's not intimidating. It's not painful. It's portable. It has all the advantages of what we would look for in a quality technology. So if we've got the numerator, what about the denominator? Because at the end, this seems to be becoming a conversation about cost, about resources, about how much we're spending. So fundamental in that discussion when we talk about costs, what are we actually talking about? Are we talking about the costs, like what's on your budget, how much you're paying your sonographers, how much you're paying for equipment, et cetera, so real costs? Or are we talking about costs that the insurers see, which are a function of charges? And the answer is both. Okay, and I'll walk you through that just for a minute because you have to be aware of the distinction and you have to be aware of how both of these play in your lab. So if we're talking about what I'll call true costs, we're talking about variable cost per case. We're talking about that which appears on your balance sheet. That's what you need to budget. That's what you need to justify up the line in your organization because that, if you will, is your spend. So if we take a look at that, you've got your fixed costs, you've got your rent, you've got salaries of your personnel, you've got insurance, you've got general overhead, which in most organizations is a function of your revenue. You've got your equipment cost and how that's depreciated over time. If something costs less, your depreciation costs are less per year. And then you have your variable costs. What are you spending it on? Well, more gel, more contrast, those types of things. The things that are purely a function of volume. So that's how we think about, the cost elements. And, Bijoy and others are going to talk a little bit more about how to be efficient and effective on the cost domain side by just how we sort of match our operations. But this other piece here about cost as to what the outside world sees in terms of what you are spending, how costly you are to them in what you do, is something that you need to have an awareness of. And I want to talk about that for the next moment or two because it's a fairly complex topic, but you need to become acquainted with it. If there's one thing you remember from this talk today, it's going to be QRUR. Okay? The QRUR report is the Quality and Resource Use Report that is generated for you and your organization by Medicare, and it is the scorecard as to how you perform. Every practitioner has a national provider identification number. Every practitioner is organized under a tax ID number, and it is by that tax ID number how Medicare assesses who you are and how you perform. The data that Medicare uses to make those assessments is fairly complex, but it comes back from claims data. So it may not have anything to do if you reviewed the chart and said, Mrs. Smith is really sick and this is why I did this. Unless it is reflected in the claims data, we don't know that Mrs. Smith was really sick. Okay? And whether we're aware of it or not, score is being kept, has been being kept, and is reflected annually in the QRUR report. A QRUR report looks like this. This is a matrix which puts a dot of your tax ID number nationally as to how well you perform with respect to whether you're expensive or inexpensive in terms of the charges you submit for the episodes of care you provide. The quality of the care you provide is also assessed on the XY. So you can see you would want to be up in that sort of northeast quadrant of high quality and low cost. And this gets reflected, and this actually plays out today. Whether you're aware of it or not, at your organizational level, there's something called the physician value-based modifier. And this is applied to basically every bill that is dropped by your organization on your charges based upon where you land on this matrix. So we will find out on July 4th how we will fare with the new rule in terms of echo reimbursement for 2018. And we're fighting over fractions of a percentage of RVU points. Meanwhile, you could be 4% above water or 4% below water for everything you do based upon how you're performing in QRUR. Okay? So this is fundamental to understanding. And if this is new to you, this is something that I would really encourage you to become acquainted with. I'm happy to speak after the session about this as well. But it's also something that I really want you to make sure you're challenging your administrative team, that they know where you stand with respect to this. So how is this helpful to you? What can you do about it? What can you learn? So here's some questions. Do your hospitals order more or fewer echoes on heart failure patients than your cardiologists? Do you know? Can you find out? How many echoes do you get for an MI patient through the year? Do you know? That's cost. We can talk about the justification, right? But that's a true cost that's up front. Importantly, how sick are the patients that you see relative to the patients who are seen across town or across state or across country? Where do you stand? How do you know? So those are the questions that you need to ask. The QRUR report, of course, being the government, it will be complex. We have what's called the Supplemental QRUR report that comes out about a week afterwards that takes a number of episodes. So we talk about episode-based care for macro, which is to come. Medicare is already doing this. They're already looking at the care we provide and bucketing it into episodes and grading us on our performance in that. So this is in a Supplemental QRUR report. So we can find out how we're doing on acute MI, heart failure, etc. We can keep walking through that, and we can see here, this is on Exhibit 1, this tells us whether we're more expensive or less expensive on various subfractions of each of those episodes that I just showed you. We can then descend down into, of the cost, if you're more expensive, where are you spending it? Inpatient, outpatient, testing, etc. Goes even further. They even give you the data, the number of cases and case level data of where these scores come from. That is sortable. So you can look at all your episodes of heart failure and see if the primary attending was a cardiologist or a hospitalist or anybody. You can see what domains the costs were, and you can actually inside your organization begin to do a data dive to figure out how you're doing. That is all reflected, again, back up in your QRUR report, and again, that's dictating how you're paid. Now, this isn't just about Medicare. What we're finding out now is private insurers are using this Medicare data to rate us. Okay? So this is an example from one such provider, siphoning the Medicare database, looking at, for each of these providers, each of these rows represents a provider, and each of these dots represents a score. So Blue Cross may say this is a green provider because he or she is incredibly efficient in what he or she does. This one is red because they're incredibly inefficient. Where are they getting their data? They're getting it from Medicare. They're getting it from the claims-based data that we all submit. So as I'm finishing up here quickly, just a couple of points. The revenue that we get is virtual. At a stroke of a pen, it can be gone, but your costs are very real, right? Okay, so how are we going to manage this? We've got to find a way to balance real costs, but by the same time we have a mission for care, the quality of care, the scope of care. So just a couple of quick points with respect to value. This is a totally subjective list generated by an echocardiographer, so echo looks really, really good on this list. But I'd love to have the bar conversation with anybody about this. And here's the thought experiment. You're going to start a new hospital. There are 4 technologies here. You get to pick 3. I promise you echo is on everybody's list. We may have debate over the other 2, but echo is on everybody's list. It's safe, effective, efficient, timely, equitable, patient-centered. But in order for it to be so, let's just not lose sight of the fact, you have to have expertise. You got to have the right people. They got to be well-trained. You got to have the right equipment. Timely, you got to have the access strategy, not only to get the echoes done, but to get the information back to the clinical care environment. And then you have to be reliable. You can't be good on some days and not good on others. You have to have a very rigid, robust QA process in place. And then in terms of the resources, again, the same discussion. Staff, we have staff costs, we've got equipment costs, facilities costs, and so forth. And I think as we look through the list of technologies in terms of the applicability of echo, we do very well in that domain as well. But once again, now we have to look at how we're applying. Is it overutilized? A low-cost test that is used too much is expensive. That point was made in the last session, and it is right on point. When we have some tools here to how to figure this out. So Linda led with this slide. I'm going to close with it, the triple aim. We've got population health concerns. We've got per capita cost concerns. We've got the experience of care concerns. We need to integrate it together, but we need to understand how it does come together and how the outside world is looking in. So with that, I'm going to stop, and thank you very much.
So good afternoon, everybody. If you needed a bio break, this is the time to take a bio break. And when Jeff and Mike asked me to do this talk, I didn't even know why I was being asked to do the talk. But then Jeff shared a secret saying that that all of the 310 labs, etc., that were surveyed, our lab came out to be one of the good labs. So some of the people from our lab who are here, thank you very much. The only bad person is me, but take it or leave it. I have no conflicts and no off-label use here. And I thought I'll give you a glimpse of what our lab is in the next 3 minutes and discuss what our best practices are. So we look at our volumes, and here you can see that 5 years our growth is 23%, and in 2016 our growth was 5%. So the good news is that echocardiography utilization continues to increase. As Jeff mentioned, it is a ubiquitous technology. If you had to build a hospital, you would pick echo before you picked everything else. But the bad news is that as the growth curve goes further and further and higher, you're also viewed as a target, because not only are you a high volume consumer, but you're in everybody's eyes. So this just shows our growth curve, and then in the inset shows the growth curve, which has also been very positive for what we call the downtown lab. And if you look at the procedures, again, large majority of the growth tends to occur in transthoracic procedures. Stress echocardiography, for reasons that are not clear to us in our own practice, is not growing but has plateaued. And transesophageal echo had a growth, but then we started doing all our TAVRs with transthoracic, so has kind of plateaued and now is again picking up as we start doing more of the structural heart disease, such as TMVR and mitral and left atrial appendage occlusions, etc. So again, to give you an idea, our lab is a pretty generic lab, like most other labs, except a little large. This kind of shows what we have, equipment, age of the equipment, sonographers. We also have advanced clinical sonographers. The lab is an open lab, but we do have 5 FTEs that are just core echocardiographers, so they spend 90 to 95% of their times just reading or performing echoes. And then for the structure to manage the lab, we have a quality coordinator and we have managers. And then for our own training and recruitment, we also have an ultrasound school. Don't do too much of academics, but just enough to keep us in the loop. And these finances, please don't copy, but the good news is that we can charge whatever we want. The bad news is you don't get paid for it. So we charge a lot of money, but we get paid just a little bit of money for performing echocardiographic studies. So that's the background. And what have we based our operational practices upon? And I would like to then share with you a survey that ASC had conducted with a company called as MedAxiom. And some of the things that they asked for in the survey is some of the things that we utilize in our lab and have been utilizing for the past 6 or 7 years as best practices. Most of the MedAxiom things also ties very well to IAC. So whatever I'm going to share with you is nothing that is out of the ordinary. And some of the key elements that is in this executive summary that MedAxiom put together for the American Society of Echocardiography board and executive board, I'm going to go over them and then apply it to our lab. We all know that today and over the next 5 or 7 years, it's going to be quality, 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 and quality. And what you can't probably read, but I'll go over it. Quality in echocardiography means image quality, application of techniques, report quality. We tend to forget that we are a service laboratory, and when we produce a report, it goes to the consumer. If we make it complex enough, the consumer either does not understand or calls for a cardiology consult, and many a times the cardiologist who is doing the consult does not understand the terms. So in the quality needs to be the critical elements of a report, what we found that we should convey to our consumers who do not always or who are not always cardiologists. They are internists, they are surgeons, they are orthopedists, they are anybody, and that they should get what they wanted, because otherwise we are giving people Chinese food when they ordered Indian food. So in the quality has to be what is very important to the consumer, and in the quality also has to be how good you are measuring your quality in the lab. What measures do you have? What peer review things do you do? How good do you treat your sonographers? What do you do to train them, increase their training, so on and so forth. The second important thing that this executive summary points out to is the business operations. And of late, I've been involved in many discussions with our revenue people, with the finance team, and they always say, Doc, do what is the best for the patient, and if it means doing the echo 6 times, go ahead and do it 6 times. And I always tell them that if of the 6 we do, if you don't get paid for 6 out of 6, next year when I come asking for machines, when I come asking for sonographers, you're going to say, you're a money-losing proposition. Why justify why you would do that? So business operations, for anybody who's an echocardiographer, you don't need to be the manager of the lab. You don't need to be a muckety-muck. Even somebody who's a sonographer, even somebody who's just a physician reading echocardiograms, we do need to recognize and we do need to keep the business in mind while not compromising quality and while not compromising the best things we can provide to the patient. An example would be, if you're doing 3D and you want to be reimbursed and you don't put that statement in, it's going to be denied even before somebody looked at it. Not that it's a code, but strain would be another thing. Or if you have done color flow imaging, but you don't mention anything about it, then when you get audited, somebody is going to ask you. So those are some of the business operations that we as echocardiographers, whether you are a sonographer, whether you are a physician, whether you are a manager, does need to understand, because if you don't get paid, you can't keep the lights going, and therefore in the end, you are harming the patient, because we all know that this technology provides enormous information, but we can't not be fiscally responsible. And then echo, when I started echo, was everybody needed to come to an echo lab. And that echoes were done in a space that is constrained, but is the echo lab. That was the Machu Picchu of echocardiography. But as you look at how things are evolving, one has to recognize that echo is a tool. Echo is a service. And the more you diversify where it is done, the better it is going to be from both utilization perspective, the need of the patient perspective, and that subspecialist who wants the echo and would prefer not to move the patient. Some of them are very sick. So again, a multidisciplinary approach, and a classic example would be cardio-oncology. Another one would be advanced heart failure. Another one would be primary care providers. If the echo machine is there on their site, they are likely to order it. If it's not there, then it is forgotten. So again, that multidisciplinary approach is very, very important. So let me go over in the last 3-4 minutes some of the processes that we use. It begins with governance. And the governance for system echo and for local echo in our practice includes sonographers, financial analysts, managers, physicians, directors, IT. And once a month, we sit down and go over all of the issues, all of the things that we are looking at future, and how we then operationalize it. The organizational structure requires we look at performance management. If there are 3 readers, and one reader is reading 26 studies, the other reader is reading 13 studies, we have a problem. It can't be that the person reading all 13 studies has the most complex one. Or if you're a sonographer, one sonographer does 8 studies, the other sonographer does 2 studies. Yes, in some instances that's okay, but then you do need to start looking into what is the reason, what can we do to help them to come up to the same level. Process management, looking at the appropriate use criteria, looking to see that this echo was ordered, but an echo was just done 2 days ago. Maybe the ordering physician in this world of electronics did not find it, or there's 1,600 other things that he or she was looking at. So then the lab becomes responsible, and the lab will call and say, did you know that an echo was ordered and this was the finding? Do you really want us to repeat the echo? So the process management is very important. In our own lab, we recognized IT was very critical. We use a single system across 12 hospitals. So we have 2 full-time IT professionals assigned just for the echo lab. so that if the system gets slow, they can fix it, or they are on the ball, they know when to clean the archive, so on and so forth. And then you can see standardization. So if an echo is ordered for source of embolism, we have a standard protocol that every sonographer follows. A bubble study, no bubble study, depending upon what the indication is, we have standardized our protocol. For quality management, I'll go over it in a minute, but then the rest of it, as you can see, we are also investigating some alternative models of payment by doing some population health, and Aurora has its own insurance. So we are looking at providing some different ways of being paid for performing an echocardiographic study, to the point that we are also now going to be working with insurance providers and going to our neighboring hospital, a competitive hospital, saying that I can provide you echo services at X dollars to your patients with a report turnaround time at so and so. Do you want us to take over your echo services? A new way of doing things. So transformational things are like subspecialization. So within our echo group, we have a group of sonographers who are TAVR trained, group of sonographers who are very structural heart disease trained, some people who do cardio-oncology, and again, that helps with the quality, amongst other things. So what are the principles, etc., that we use? We optimize the way in which services are provided. We now have echo labs in the advanced heart failure clinic, in pulmonary hypertension clinic, cardio-oncology clinic, any sub-area where we think that the echo is being utilized or is underutilized, we now provide on-site echo services. For example, one of the things that we are looking at as we do some of the refinement is, why does a patient from floor X need to come down to the echo lab? Why can't we have an echo lab on an intensive care unit floor, another one on another floor, and then feed those echocardiograms to the reader in the reading facility? We are also looking at some of the other things that are mentioned on the slide, such as practice standards, so on and so forth. And how do we maintain quality? We have a monthly quality meeting that looks at quality, randomly selected, or somebody refers because the EF was 35% and suddenly became 45% and suddenly became 26%. That is something that one needs to rely on, look at it again, and then we start our education process. We also have a measure that is tied to physician compensation, which is the report turnaround time. So for any inpatient in the Aurora system, from the completion of the study to a final report, 4 hours is the maximum time that is permitted. And 30% of the compensation of an echocardiologist is tied to meeting that metric. So if you don't meet the metrics, 30% of your salary you leave behind for your colleagues to share. And then the rest of it, as you can see, we go through a critical reports process, again utilizing some of the standards that exist, that these are critical findings that we need to report. And we also have for quality improvement weekly conferences. We have a learning lab, so whenever a new technique is involved or some of the old techniques that we think needs more work, we have people sit down in the learning lab and then practice it and learn with a tutor, and then we have super users. So, ladies and gentlemen, what I've tried to give you is a brief overview on what our lab does to try and preserve the quality of echocardiography, quality of sonographers, quality of physicians, and yet not losing the business perspective that if the lab does not have a contribution margin that is positive, the likelihood of this whole palace falling apart is very, very high. So with the operations team, we work once a week We have a meeting to look at all of these things and try to come up with what improvements can we make, what can we follow from ACE, what can we do to work on the IAC criteria that we may not have been doing. Thank you very much.
For those of you that don't know, be a scientific session chair, it's a 4-year commitment, essentially. And I remember about 4 years ago having a conversation with Jeff and debating about whether to go into that long-term commitment. And I'm really thankful that you decided to. We are the beneficiaries. All right. So my payback for this has been getting a phone call from Jeff and saying, hey, I want you to be part of this value summit. It's going to be great. And I said, sure, I'd be happy to do it. And then I get the assignment to look at bundling and episodes of care. And while I have no disclosures for the talk, my real disclosure is when I think of bundling, I think of this. It's like bundling, right? You just put those pieces of wood together. So like any good academician, I immediately go to Google and I look up bundling. And I learned all about bundling products. I learned something new in preparation for this talk. There's a thing called a bundling board. And I hope I never see that any time in my lifespan. Obviously, bundling prices, we all know about that. But what we're here today is to talk about bundling of services. So if we have such an expert in bundling, why is he up here giving this talk? Well, I think what I'm going to do is give you a perspective, a little bit different perspective, actually, of what's happening in Maryland, the ultimate bundling experiment going on, and what I've seen, and then how that could be applied to echocardiography. I'm from MedStar Health. It's part of Georgetown Washington Hospital Center, a 10-hospital, 280 points of care, integrated healthcare system across the Mid-Atlantic, across Washington and Baltimore. These are our points of care. So you can see we have a big system here. And as you heard this morning, Maryland has been in this really interesting 40-year experiment. And you had one of the key administrators that helped design and refine this 40-year experiment. Maryland, for anyone that wasn't here this morning, Maryland is an all-payer system. So back in 1977, essentially it was a price fixing in a way. There is this independent panel called the HSCRC, the Health Services Cost Review Commission, who sets the price for different things in each hospital. And it's for everybody in that hospital. It is a true rate setting. It is the opposite, in a way, of competition. This means that no matter who is paying, whether it's a private insurer or the government, and I live in a research world, so if it's sponsored research and the sponsor of the research needs a service or a product, they pay the same thing as Blue Cross as the government. So it's one price for a particular fee for service in a particular hospital. Now, that was allowed as long as it meets the waiver, that growth in Medicare spending for inpatients is less than the national average. And this has evolved over time, and over the last, since 2011, there's quality metrics that fit with everything that we're doing. The QBR, quality-based reimbursement, is all there, and along with hospital-acquired adverse events. So how has this worked? Now, you didn't see this slide this morning, okay? Although somebody asked it, it's like, so is it much cheaper? Is healthcare much cheaper in Maryland than everywhere else? And the resounding answer is no. In fact, it's one of the most expensive places in the country to get care. We were #1 in 2007 to 2009, the most expensive per capita place to get inpatient hospital care. And you could just see where it fit. So it really has not worked, but it keeps getting extensions and revisions and so forth. Now, why has it not worked? Well, it's not worked in large part because it's still based on fee for service. The rate setting is set on units of care, units of service. And that fee for service incentives still helps drive volumes. And the waiver test looked at per capita Medicare inpatient, but not total cost of care. So as you heard this morning, a number of people got in the back room, and said, what can we do about this, because I don't think this waiver is going to get approved going forward, and came up with this idea of a global budget revenue. How about if we just shift away from the fee-for-service and put all the risk on the hospital? Give them a fixed amount a year and let them figure it out. Yeah, I think that would be good, because then that would finally force them to decrease that avoidable utilization, because those bad hospital guys are just spending money without any sense of responsibility. I'm being a little cynical here in the way I'm presenting it, but in essence, that's what the GBR was. It's a fixed amount. And this was a sea change that we went through, a remarkable sea change. This happened in January 2014. So now, Hospital X gets a certain amount of money for whatever they do, for whatever number of patients they see. It's their responsibility to keep the costs down. If they do that, and they have an excess, they could reinvest it. If they don't do it very well, and their costs go above the amount that they get, they're underwater, and they're in the red. And again, I think the question was asked, I don't know if the question was fully answered, how's that working out for the hospitals? Well, not very well. I mean, we were on a path that more hospitals would go out of business in Maryland than any place else. And clearly you heard that the academic medical centers, which obviously are overrepresentative in the representation of this independent panel, are looking for exceptions to the rule for drugs, devices, all the infrastructure that we need. So there's a lot of work. And then the other thing you heard is that there is a readjustment that's done each year. They look back and say, the market shifted. There's less people in your area than in other areas. So it's not completely volume independent. So what did this waiver essentially, this new global payment says that you've got to meet three major financial benchmarks to keep it going. And this is through CMMI, the Innovation Institute at CMS. You got to keep overall hospital spending under what the growth rate is in Maryland, or expected to be, of 3.58. So there's an absolute amount for annual hospital spending. There's a dynamic amount that we need to save money, okay? So we want to make sure that Medicare is saving a total of $330 million over 5 years. And then that there's a relative amount of the growth in total state Medicare spending. So that's not just hospital. Total state is not going to exceed national growth rate. So you heard some of this. The first 3 years look pretty good when you look at these metrics. The percent growth is well under the 3.58. In fact, this number became negative in the last few months of calendar 16. The total savings, I actually saw the numbers for the first time. This was through September, was 428. We saw $538 million of savings. But again, I'm going to give a little different perspective here. What you didn't see, on this 29 million, about 220 million of that got shifted to outpatients. So there was a savings on the inpatient side of 428, but if you subtract out what got shifted to outpatients, that saving is actually did not reach the 300 million mark. Okay, so you got to really look at what's happening on a more global scale. Here's the benchmarks that include the quality benchmarks, and again, they do look good. So overall, the GBR is achieving the majority of the goals, but it is coming at the price of squeezing the hospitals more and more and more, and making the sustainability of the hospital harder and harder. So what does this really mean? What are the hospitals really doing? So I decided to pick a very local example. 3 miles south of where we're sitting is a very nice community hospital called MedStar Harbor Hospital. Want to guess why it's called Harbor Hospital? It sits right there on Baltimore Harbor. Beautiful rooms, nice water view from the rooms. It is truly a community hospital. It is in a very poor section of Baltimore. And one of the initiatives that they did here at Harbor was they looked at where they were losing the most money, and no surprise, it was people coming into the emergency room that had uncompensated care. And they said, what could we do about that? Well, if you look, the emergency room is right over here at the edge of the hospital, and right next door, just like at many places, is a physician office building. And they use some of that space to ramp up their clinic, including their walk-in clinic. And then you look at the cost of what it takes to take in this uncompensated care, and particularly how they're using certain resources in the emergency room. And they placed a nurse practitioner right there as you check in to help educate the patients. And during that education, it says, you know, you've got this. The current wait is 5 hours for something that's low acuity like this. By the way, do you know that right next door there's a walk-in clinic, and right now I'm showing a 15-minute wait for that walk-in clinic. So they could get the type of care. Or you could wait 6 hours for this, but 9 out of 10 people get this taken care of in a doctor's office with the next day appointment. Do you want me to help make an appointment? So getting care, and it's all appropriate educational advice, but it's getting care to the right setting. That decreased the emergency room volume by almost 20% in 1 year. Okay, so that's just one example of how the costs were changed without compromising the care. It's actually driving us to do it. There's all kinds of interesting things happening, including a big ramp up of case managers, social workers, people doing home visits, and there we'll get this going. So it's very interesting, and I think it's great because it is driving us to provide better quality care. Let me now get to why we're here, because we don't all live in Maryland, and I haven't talked about echocardiography yet. But one of the things that you'll notice too is I don't only live in Maryland, I live in DC. And DC is a very different payment system. We know that we heard earlier that cardiovascular care is being bundled, and I think that at least for someone like me, we needed to look at what the bundling is and how it's going to be applied to cardiovascular care. And bundling is a building blocks of lots of different things. Don't have time to go through all of them, but I want to hit a couple of the key things so we could see how it applies to cardiovascular care. So, first, there's the service bundling, okay? And defining what that is, the condition or the procedure. Now, a procedure is nice and tight, and then there's a timeline around that procedure. But a condition gets a little murky around the edges, okay? Acute MI, you come in with a stroke and you have a troponin rise, that gets lumped into the acute MI. Also, you got to look at the timing, because if you know, what happens on day 89 is dramatically different than happens on day 91. And it is, there's a possibility of being able to shift things. The bundler. Who could bundle this? One of the questions was great about rural hospitals. You got to be in a setting that you can have true integrated care across a whole network. The value proposition, and where is that value proposition recognized in your system? It's only going to work if everyone's working off the same books and have the same motivation and incentives, that a true savings is helpful and it's not split between just departments. The care management, truly coordinated care, truly handoffs between different care settings, inpatient, outpatient, sharing goals and so forth. And there's a whole bunch, outcomes, assessment, payment, IT strategy, which really gets into the last one that's crucial, is data analytics. You've got to have data if you're going to be able to be successful here, and have feedback loops in that data, including being able to look at geographic distribution. So I just pulled some data from one of our Baltimore hospitals. That's the geographic distribution for one of our busy emergency rooms for stroke. One of actually the busiest emergency room in the state of Maryland, north of Baltimore. That's the distribution for stroke. That's the distribution for heart failure. That's the distribution for joints. So you got to be able to deal with all of this depending on what your bundle is. Okay, so let me do this. So what's going on in terms of bundles right now? We need to learn from the comprehensive care for joint replacement. What's happened there? They're a good year or so ahead of us, and have 788 hospitals, 23% of joints involved. We learned that For the cardiovascular bundles, initially it was July 1st, then October 1st, now it's January 1st. Tom Price clearly has been outspoken against is not a fan of bundles, and I would not be surprised if there's continual reassessment of them and delays or changing to voluntary status. Where are we going to fit in as these bundles come out, and what's going to be the role? So if you, acute MI and CABG are the two bundles that are out there. For acute MI, we all know the value of echo for acute MI. I just pulled from the appropriateness criteria, just looking at the role of echo in the diagnosis and early management of acute MI, all highly appropriate. We know for risk stratification, early after an acute MI, the importance of LV function. This data is 10, 20 years old. We know that is an important prognosticator that we use every day and does help manage the patient and helps get them the right care. It will be cost effective by knowing this information. We also know that even with an intervention, with acute MI, a PCI, that the information we get from echocardiography is important to help manage that patient. This is information on the RV looking at fractional area change and for strain. So even if we know the LV function is incrementally better than just clinical, but RV function is even more beneficial. It has additional incremental value. Complications soon after, we know about the importance of echo. And here again, this is a direct tie between operations and finance. We want to do what's right for the patient, but decrease the cost. Well, by taking a look at LV function and knowing what is the likelihood they're going to need a defibrillator a month down the line, that is best for the patient and best from a financial point of view. So those are the type of things where echo is going to come to the forefront. Given the time, I will just go very briefly on CABG. Again, has a role in prognostication, understanding the risk. This is just Euroscore. And has a role in, again, I picked a thing where good medical care fits with good financial stewardship. Predicting rehospitalization. So we've got data out there looking at RV function to help predict rehospitalization. Clearly, they're patient, and we are interested in preventing mortality and predicting that. But even if you just look at the cost, there's a role of echo to decrease the cost. So those are the things that we're going to need to pull out when and if bundles come forward. Innovation, the last slide, I like this. Because I think it's relevant to what we're talking about here today. Innovation and value are sometimes, I'll put sometimes in there, sometimes less and less dependent on the science and more dependent on how we deliver the care. Thanks for your attention.
Well, thank you, Mike, and thanks, Jeff, for the invitation to come here today. I'm going to take a step back. We've been forward-looking. Going to take a step back to current day, and before we do that, first of all, I have no relevant disclosures. Let's go back even further, about 50 years ago, kind of the origins of our current fee-for-service reimbursement scheme. Take you to the Harry S. Truman Library in Independence, Missouri, July 30th, 1965. Then President Johnson traveled there. The purpose of that visit was to sign the 1965 Medicare Amendment to the Social Security Act establishing Medicare. And return to the library, as you can see there, about 6 months later. The purpose of that visit was to hand out the first 2 Medicare cards to the former president and first lady. As you can see, they're very enthusiastic about this new insurance program, have very high hopes for that. It was going to take effect then about 6 months after that on July 1st, 1966. Well, it's important to remember, it's often forgotten, that the American Medical Association was vehemently opposed to the Medicare program. They said it would be the beginning of socialized medicine, echoes of that today with current healthcare policy. They took out ads in about 100 newspapers, and they were pushing their own plan, which they called elder care. I think it has a nice ring to it, actually. It was a plan to be pushed as an alternative. That obviously failed, and why did it fail? Well, To placate the AMA, the United States based reimbursement on local calculation of what was called a customary, prevailing, and reasonable fee. Now, there's some unintended consequences that should have been predictable, including the fact that the rate of increase in physician fees quickly doubled. Physicians routinely charged the United States 2 to 4 times commercial insurance rates. That led President Nixon in July of 1969, the same month that Apollo 11 landed on the moon, to declare that we had a health care crisis in the United States. Finally, 20 years after that health care crisis was declared, the Omnibus Budget Reconciliation Act of 1989 changed Medicare physician reimbursement from these customary, prevailing, and reasonable charges to fees based on the resources needed to provide those services. So the question obviously comes up, how do you determine those resources? Well, at this point, the American Medical Association, the old enemy of Medicare, re-enters the scene, and they establish a committee called the American Medical Association Specialty Society Relative Value Scale Update Committee, oftentimes shortened to just the RUC. Well, this is an expert panel formed to make recommendations to CMS on relative values of new or revised CPT codes. And it's a political process, really. It's the process that decides who gets what of what there is to get out of a fixed pie. And these recommendations then are used by CMS in developing annual updates to the Medicare relative value scale. And although it's independent, the RUC really serves what I would term a quasi-federal role in that CMS typically accepts about 80% of the RUC recommendations. That's actually down a little bit the past few years. The RUC does represent the medical profession as a whole, in that 21 of the 31 members are appointed by national medical societies, and there are 300 medical advisors, including now over the past several years, the American Society of Echocardiography. Now, this RUC process has been heavily criticized by some. This is a cartoon from a paper in Washington Monthly a few years ago, and some of the criticisms of the RUC process are that specialists may hold more power. There's potential for collusion amongst specialists. There's secret meetings. There's lack of transparency. It favors procedures over cognitive skills. Physicians determine at least their own valuations, if not their own fees. And, of course, there's always allegations of price fixing. How would I respond to that after observing the RUC for a few cycles? Well, probably a little bit guilty. But I would also echo what Winston Churchill said about democracy. He said it's the worst form of government, except for all those other forms which have been tried from time to time. I think it's probably true that the RUC is the worst form of valuation, except for all those other forms which have been tried, including having just Washington bureaucrats make these decisions independent of practicing clinicians. Well, there's a project you ought to know about, and that's the RUC Potentially Misvalued Services Project. Potentially misvalued is really a CMS euphemism for likely overvalued. And what the CMS did, the Centers for Medicare and Medicaid Services did a few years ago, is they ran what they termed a high expenditure screen. They identified all Medicare services that cost the program greater than $10 million per year. I think we all probably know of some individual patients that cost the Medicare program over $10 million per year. And they referred these then to the RUC for reevaluation. And what does the RUC do? Evaluates three things: physician work, practice expense, and then a small component of malpractice expense. What's happened in this program so far? Not really too great on the physician side. As you can see here, 17% of codes have been deleted. 38% have seen a decrease. 24% have had their value reaffirmed. Only 8% have seen an increase. So reaffirmation of current value is actually a huge win when codes go before the RUC. Now, we've had all of our major codes go before the RUC, and what's very critically important in maintaining value at the RUC is physician survey responses. That's a key data point that the RUC uses, and as you can see, the ASE has really pushed this, and we've had very good survey responses. Our transthoracic codes were reviewed in April of 2016, the 06, 07, and 08 code, and then our stress echo codes were reviewed by the RUC in October of 2016. Well, there's another panel that you ought to be aware of, and that's the Current Procedural Terminology Editorial Panel. That's a 17-member panel, 11 who were nominated by the AMA. What are CPT codes? Well, they're really just a list of descriptive terms and identifying codes for all medical services and procedures. And it's important because they form the basis for HCPCS codes. What does the CPT panel do? Well, they evaluate these code change proposals. They can either reject them, they can establish a Category 1 code, which then is RUC valued and CMS reimbursed, or they can establish a Category 3 code. Now, that's also called an emerging technology or tracking code. So if we put all this together, it's really a process that runs like this. CPT describes the work, the RUC process values the work, and then CMS actually provides coverage and provides payment to physicians and hospitals for provision of patient care. Where do we have points of influence as ASE? Well, we actually have an advisory position at the CPT. We have an advisory position at the RUC. And we can then go to the table at the RUC when our codes are presented. We can comment on that, make our arguments, and present our physician surveys. And of course, we also have the ability, and have gone, to the Centers for Medicare and Medicaid Services over the past several years when we've disagreed with CMS policy. Well, how can you help ASE? You can help ASE by joining the AMA. Actually, our advisory positions are contingent on our membership in the House of Delegates. And the House of Delegate position of ASE, which Peter Rocco is our representative, allows us then to have these advisory posts. We have to have a certain percentage of our membership also members of the AMA, at least 1,000 members. So in 2018, when that rolls around January 1st, please make sure that you're a member of the American Medical Association to help us maintain this critical position. Well, one thing the ASE has done over the past few years is develop 3 new CPT codes for echocardiography. And although we're going towards a value-based payment system, we're still in a fee-for-service world. Why else is it important to develop these new CPT codes? Well, in some senses, I think, echocardiography has what I'd term an image problem. This is a quote from Eric Topol in 2014. He said that echocardiography is a stable technology that hasn't changed much in decades. Now, if we subject him to a polygraph, we'll see that that's actually a false statement. However, the public, I'm afraid, kind of has this impression. The first of these codes that we presented and were successfully implemented with the interventional transesophageal echocardiography code. And you can see here a slightly off-label use of an ASD closure device in which we permanently closed the aortic valve in a patient with LVAD-associated severe aortic regurgitation. TE was obviously critical in getting this procedure done. And what did we submit? We submitted 93355 when we did this procedure. That's echocardiography for guidance, echocardiography transesophageal for guidance of a transcatheter intracardiac or great vessel structural intervention. Now, this is not monitoring. This is not purely diagnosis. It's a guidance code. Very important. It's a Category 1 code. It's valued by the RUC. It's reimbursed by CMS. It's been live since January 1, 2015. It was submitted 10,365 times in 2015, 12,000 times in 2016. And I think that's actually significant growth because, as Dr. Canderia alluded to, we're actually performing more and more transthoracic echocardiograms during transcatheter aortic valve replacement procedures. So this is a growth in the other procedures, left atrial appendage closure, edge-to-edge mitral valve repair, etc. The work RVUs are higher for the 5.5 code, 4.66 versus 2.55 for the diagnostic TE code, and that better accounts for the physician time and intensity to perform that procedure. Well, there's now also a myocardial strain code. It's been alluded to before as well. This is just an example of using myocardial strain to better characterize a patient with cardiac sarcoidosis. The MRI and PET-FDG images also there in panels A through C. This code change proposal was submitted in 2014, presented in February of that year, and the CPT panel ultimately established a Category 3 add-on code for imaging of myocardial strain to assess myocardial deformation. That code went active January 1 of 16. It's important to report that code 0399T when you perform myocardial strain imaging. Now, as I mentioned, Category 3 codes stand for emerging technology, sometimes also called tracking codes. And while they're not CMS reimbursed, they may be reimbursed by private payers or Medicare administrative contractors. There's a strain code toolkit available on the ASE website that may be helpful to you as you talk to payers. And there's an opportunity for this code to progress to Category 1 status in a couple of years if we can demonstrate significant utilization and if there's additional peer-reviewed literature which substantiates the clinical utility of the service. Based on this meeting, I don't think that will be too much of a problem. This is the strain code reimbursement toolkit front page. Again, it's available on the ASE advocacy site. This is just a map of the Medicare AB administrative contractor map for the United States. In my region of the country, it's Wisconsin Physician Services. Last year, the ASE partnered with the ACC in outreach to the MACs, asking for strain reimbursement in one clinical scenario, and that's in the cardio-oncology patients. Now, this is awaiting right now Noridian's decision in their listing of proposed local coverage determinations, which will be published on July 1st, 2017. Finally, we have a myocardial perfusion code. Shown on the left is no reflow in acute MI. On the right, stress myocardial perfusion, echocardiography, both emerging techniques. That code change proposal was submitted in 2015. We presented that in October of that year, and the panel ultimately established a code for myocardial contrast perfusion echo at rest or with stress for assessment of myocardial ischemia or viability. That code now went active on July 1st, 2016. It's important to report that code, 0439T, if you perform that service, myocardial perfusion at rest or with stress. Another issue you ought to be aware of is billing for TE sedation. This has just recently emerged. Before January 1st, 2017, moderate sedation reimbursement was intrinsic. It was automatically included with diagnostic TE services. Now, CMS became aware that in some cases, anesthesiologists were performing sedation for TEs. The cardiologist was performing the TE, but an anesthesiologist was administering sedation, essentially double billing, although unintentional. So now when a cardiologist performs a TE and administers moderate sedation, charges for both components must be submitted or the moderate sedation reimbursement will be lost. What does this look like? Well, putting it very simply, if an anesthesiologist administers a drug like propofol while you perform a transesophageal echocardiogram, simply submit 93312, your diagnostic TE code. If, on the other hand, you do the conscious sedation as well as performing the test, giving, say, midazolam and fentanyl as we commonly do, submit 93312 and then also submit the code 99152 for the first 15 minutes of moderate sedation and 99153 for each additional 15 minutes of moderate sedation. The additional minutes, unfortunately, only available for reimbursement if it's performed in the physician office setting. Obviously very unusual, most of these being performed in hospitals today. So keep that in mind. We do have some information on the ASE website, on the advocacy webpage, concerning billing for TE sedation. You can see the link right there if you would like more information. Most of what you need to know was on the last slide. And finally, I think, while it's important that we're compensated for all the services that we do provide, we need to attempt as cardiologists and sonographers to limit low-value care. This is a project instituted by my colleague Bethany Austin at St. Luke's Mid-America Heart Institute in her role as chief of the evidence-based practice team for cardiology. And what this is basically is a best practice alert that pops up on inpatients whenever an echocardiogram has been performed within the past 6 months. And essentially, as you can see at the top of this alert, it says to the physician or the nurse practitioner, this patient had an echocardiogram within the past 6 months. Please consider if repeating at this time will change clinical management or decision making before ordering. The default here is to remove the order, but the clinician can very easily change that to keep. If they change it to keep, they're asked to provide some reasoning for that, add some comments. And what have we found with that? Well, over the first few months, this best practice alert has popped up 1,500 times. 38% of the time, the clinician actually removes the order, acknowledging that this test is not necessary, that it actually is low-value care, and that has obviously freed up resources, both physician and sonographer, that can then be applied to patients who actually need our services. So a few take-home points. The AMA CPT editorial panel and the RUC committee heavily influence CMS decision-making regarding medical services and reimbursement. Transthoracic echo and the stress echo codes have been recently RUC reviewed. We await now the CMS proposed physician fee schedule rule, which will be out next month. That will be for reimbursement starting on January 1st, 2018. Also important that ASE has recently spearheaded 3 new CPT codes, interventional TE, the myocardial strain code, and the myocardial perfusion code. I think it's quite likely that within the next few weeks we'll have a proposed rule with one Medicare administrative contractor, Noridian perhaps, that will cover limited strain imaging in the cardio-oncologic arena. If you provide moderate sedation for transesophageal echo, please ensure you're submitting the proper codes for that. And I think finally we need to be creative in reducing low-value care, similar to the project that we just discussed. Thanks very much.
Thank you, Mike. We've had some really great presentations over a really diverse area of this issue. I've got a lot of questions here. I apologize in advance if I don't get to all of the questions, if I don't get to your question, but please come up at the end of the session. Our speakers will be happy to stick around and answer them. And I'm going to just try to rapid fire go through a lot of these. But first question, maybe if I ask each of you to give a very short answer. You guys are clearly very knowledgeable about all this stuff. Where did you learn it? Are you reading the Harvard Business Review, or is there some website that you're doing this, or is it just paying attention at the meetings in the hospital? So, Mike, where did you learn all this coding and reimbursement stuff?
A few years ago, Jim Thomas asked me to do a little reimbursement work on a very small project that was going to go on for a month, and that turned into about a 5-year project. So just as you said, just kind of paying attention, going to meetings, and reading. That's essentially it.
Neil?
I told you already, Google. I think the practical knowledge, I get to sit in a monthly meeting where chief medical officers from the different hospitals are there and the heads of the service line. So these topics come up all the time.
BJ?
Same thing. I sit once a week with the administrative team, the finance team, the coding and reimbursement people for the service line, and ECHO is a big component, so I learned from that.
Yeah, I think on the job reading, and then, from colleagues. I've learned so much from Mike and others on advocacy. There's sort of a shared learning that goes on.
So I think the message is, although some of these executive business school courses are really neat and cool, you don't need to go to school for this stuff. I mean, this is on the job. You can learn this stuff by just asking your administrators a lot of things.
Yeah, and I'll actually even go further than that. I had the opportunity to take some courses at Wharton, and they're out of date. Those academicians in business schools actually need to learn from us. These things are moving so quickly.
Okay, let's see what my next question will be. Oh, here's a question, a very simple question. What is the RVU and the reimbursement for that, the sedation code, the 152?
Yeah, it's actually very low, and that was something. It's under 0.2. Yeah, it's under 0.2. Yeah, it was actually something we were heavily involved in. Since it was being carved out, we wanted that to be as low as possible. So there was a lot of work on that as well.
Another person, I'm going to get through these really nuts and bolts ones. If you're performing sedation during a focused or a limited TTE, can you use that sedation, that moderate sedation code?
Transthoracic?
Transthoracic.
Sedation?
Yeah. I assume that maybe is a pediatric.
Pushing really hard?
Probably probably some of the pediatric patients.
I don't think so. I don't think so.
Okay. Several speakers have mentioned the IHI triple aim. Thinking about what we will need to adapt to new patient models, shouldn't we consider focusing equally on improving the proposed fourth limb of this aim, staff engagement and satisfaction? So, interesting. So we haven't really talked at all. I think BJ mentioned a little bit about the personnel issues here. How do you keep your sonographers engaged, practicing at the highest level? We don't have as many incentives for travel to meetings, things like that. So how do we deal with that?
So at our place, we have a staff engagement survey for the sonographers, for the nurses, and for the desk personnel. And the manager is judged on that. The director of the lab is judged on it. And then we did poorly this past year in our survey. So then we now have a meeting with them, an open door meeting, look at what the biggest thing was, that they had parking issues. That's why the engagement survey was poor. So now we are trying to fix the parking issue, which is not a very easy thing to fix. Last year, the cath lab they never got a lunch break, and they had to work through their lunch. So we are trying to fix that. And then for just improvement every week, Matt, who I don't know if he's here, but he's our quality coordinator. He sits down with the sonographers, and sometimes I sit down or another staff sits down, and we go through echoes on a weekly basis and say, this gain setting is this much, you could have done this, or this strain or speckle was incorrectly done, you could just set yourself up. And then finally we have the computer lab that we use for training some of the new sonographers.
So Bijoy, there was a question here about the learning lab or these sort of sessions. Obviously, a sonographer is not actually doing a case then, but you're paying them during that time. How do you justify paying for I'll call it non-clinically productive time?
So it's a very good question. We don't actually call it a non-productive time. We actually built into our scheduling that there will be some blocks of time that we call as sonographer education time. And it's kind of built into the overheads and indirects and works very well. And if your engagement surveys are low, it bumps it up right away. So,
Neil, you had a comment.
I want to comment on that question because the importance of staff engagement, look, it's mom and apple pie. We want everyone to be happy and engaged, right? Well, we know, and we're just rolling out our associate survey results now, healthcare engagement has gone down a lot nationwide. People are not happy because they're getting squeezed. And when you get squeezed and you have less resources and you need to do more, you're not happy and you're certainly not engaged. So what are we going to do about it? So each of us in our own position could think about what we could do from our own position point of view. But the big win, go back to bundle payment, global payments. What's the financial motivation for staff engagement? What's the cost of not having staff engaged? Those are the conversations that have to happen between the operations and the finance. Put it in the terms, financial terms. What is a cost for staff turnover? Once you have those conversations, all of a sudden it makes financial sense to have engagement. And that's
but I think the physician has to drive that because the administrators are not going to drive that.
It's got to be an education of the administrators from their viewpoint.
Yeah, so, I mean, you have proxies for it, exactly right, in terms of staff turnover and so forth. And a lot of the things we're doing, admittedly, are really Band-Aids. Until the payment structures actually support the triple aim, we're going to be trying to push solutions at a problem. If you're being evaluated on RVUs and productivity per minute, and yet we're talking about these aspirational aims in the triple aim, there's just a disconnect there that is really hard to come over. Once we do get to these, and we should really be looking for these value-based payments because it's a return of professionalism. None of us want to do an echo that's of low-value care. None of us want to do an incomplete job. But too often just the situation drives us that way because we just can't stop because we're responding to the fires that we have to put out. So we're actually sort of caught at this inflection point. And the faster we can get to these other models, I think the better it's going to be for us as a profession in terms of our satisfaction.
Here's a totally different question, and then I'm maybe going to spin it a little bit also. It says, what happens when both the numerator and the denominator of the value equation run low? In other words, quote, good enough reports from outdated machines that are fully authorized is cheap, but not valuable or valuable. How do we, I think this gets into this, we can take an old machine that doesn't have the latest upgrades on it and probably get the bare minimum work done, and then obviously save a little bit of money versus pay for the upgrades and have the latest and greatest technology. So how do we fund innovation and keep our equipment at the top of the pack when we're getting squeezed in terms of trying to manage the costs?
So I'll let Mike comment on that in a second, but just to, put it out there, obviously you get paid the same amount for a machine that's 10 years old versus one that you just bought. So that's, the problem. So I think what you really have to do is within your service line have greater and greater applications for the machines that you have and have what I'll call capital intensity, right? Whether you're running double shifts, whether you're, the depreciation cost is the same. It's a function of time. How many studies are you getting out of that machine and how much time is it collecting dust in the corner? right? And these are things we have to start thinking about again. You know, does somebody have to take a day off from work to get an echo, or do you have a situation where somebody can come in before work and get that echo done, or after work, using the same machine? But if that machine's only being used from 8 o'clock to 4 o'clock, well, now there's a lot of time that it's not. So we really have to be focused on capital intensity as a way to drive support for this kind of equipment.
Well, I just comment, I think that your first comment's exactly right. They're both reimbursed the same, and that's a real issue when you talk to administrators. They're not going to see any additional revenue from new equipment. I think we have to convince our administrators as part of the team that there is such a thing as technical obsolescence and that we need to have long-range plans for machine refreshes. We're working on basically always on a 5-year plan for refreshing machines, looking at a service life in the range of 6 years or 7 years per machine at the outset. And I think if you don't do that prospectively, you're going to run into trouble.
So those Category 3 codes highlighting these new technologies, clearly if you don't have strain on your machine, then you can't use strain during cardio-oncology, you can't build a Category 3 code. So there's a place where we're collecting data to hopefully justify some of the new technology. My question, Mike, many of us are now using electronic medical records that sort of do the automated billing. And I'm not aware that the Category 3 codes are actually built into those modules. And how are you billing a Category 3
Well, that does have to be built out, essentially. Yeah. So that's what we did when these codes went live. We had our billing department add those codes in so they could be used.
So your site is doing this independently of the vendor of your EHR?
Correct. Right. You have to individually build those in.
So we've got a lot of inefficiencies here because, I mean, probably all 5 of us are using EHR, and all 5 of us have to do it ourselves. Same thing with the AUC. You had a really nice pop-up for ordering, but that you had to develop. We've had to develop the same thing, whereas it really seems like we need to go to the vendors and say, these are mission-critical things that you need to build into all EHRs. And I don't know if it's the ASC that can do this, but somebody really needs to speak up so that we can share what we've learned.
That does seem to be a problem with these medical records, obviously the largest Epic, which we're probably all on, and that is that people have had good ideas, just like Dr. Austin did at our institution, that's not being applied nationwide. And you think that those best practices could be basically disseminated and then adopted in a large setting.
Yeah. So can we all contact Dr. Austin?
You can. She's here in the audience. She'd be happy to talk.
Great. And I know several other people in the audience have these same things where we've all done things, and somehow we need some platform to share a lot of that information. Okay. Let me see. What's the other one that's good here? The quality of your echo reports. Bijay, you talked about sort of best practices, and you mentioned how our referring physicians sometimes just don't understand the mumbo-jumbo in the report. Is it your feeling that we should be providing treatment recommendations to actually at the bottom of the report so that they really get the bottom line, or do you just leave it at you spell it out and let them handle the
So
next
at
step?
least for our practice, we have decided that we are going to only report on the echo and not provide treatment recommendations, because many a times we don't know the rest of the story. And if you don't know the rest of the story, for example, somebody said if you have grade 3 diastolic function, prescribe an ARB, but that patient may be intolerant or something. So we have kept echo to just diagnostic. But what we do is that we simplify it, so we don't kind of go into 3A.1 diastolic function. We report mainly the filling pressures. We don't sort of say grade 2-3 mitral regurgitation.
But you don't say consider adding diuretics?
No, we don't say that.
Okay. Bijay mentioned the parking an echo machine in heart failure clinic or up in the oncology suite. I imagine that there are going to be days when they're going to be busy in LVAD clinic the entire day, and that machine's going to get 8 or 10 cases done. But then there may be days where that machine only may get 1 or 2 cases. Is that an issue? How do you balance that out? I mean, our operating rooms now sort of on an hour-to-hour basis, they decide when to open and when to send the nurses home because they don't have cases. We haven't done that yet in the echo lab, but is that on the future, or how are we going to smooth out the utilization of an echo machine?
For us, it's not a problem.
Okay.
For us, if that happens, we would have a field day with sonographers, etc. The other thing I did want to mention is that we tend to forget, but machines that were old consume a lot of power. Machines that are new don't consume power. So in the efficiency and the operating cost of an echo machine, you always have to factor in the room, what's the power consumption, and some places the electricity cost is very high.
And hospitals are now going for these LED
monitors, displays,
recognitions and things where a green building, well, you want to have green machines also. So that's a good
and
point.
you have to consider, because we looked at it and the cost of power was astronomical. So as you mentioned, we do so for people who are working people, we have different hours, and therefore we can also give our sonographers staggered time. Somebody has a family, they would like to do 4 10-hour days. Somebody who doesn't have a family would like to do only 8-hour days. Some of them want to work late in the day, and some of them want to work early in the day. So again, we want to utilize that machine to the maximum possible, and also keep the sonographers happy by accommodating the schedule.
There have been a few questions about really the specifics of what we can expect about reimbursement. So I guess I'll first ask Michael. Here's one that says, what do we anticipate are the greatest at-risk areas in echo for the coming year with the proposed rule that's going to be coming out soon?
What are the greatest what?
At risk. I guess, are we looking at, you think, staying the same, going up, going down? What codes do you think we're going to see changes?
Well,
I know you can't tell us the details, but in general.
2 rules come out, obviously, the hospital outpatient department rule, the preliminary rule, as well as the physician fee schedule. What I was talking about was basically physician reimbursement, which will be on that PFS proposed rule. So all of our codes, with the exception of TEE, are actually at risk, including all of the echo base codes and the stress echo codes. Those were all basically surveyed and valued by the RUC. All of that will appear in that proposed rule. So I think that current valuation, that's what we're hoping to get. Obviously, an increase would be nice. That's very, very rare. And as I also said, there's been some delinkage between RUC recommendations and CMS action over the past several years. So a good outcome at the RUC does not guarantee that CMS will follow suit.
But we're keeping our fingers crossed that most codes will stay the same.
Very much so.
If you need to make some predictions and you're budgeting, that would be...
We certainly hope so.
Okay.
Yes.
Here's just, actually, this is one we should just, let's do for the audience. Everyone by show of hands. Someone asked, is anyone running evening or weekend outpatient? So how many people run outpatient hours after 5 p.m. in your practice? Okay, a few. On the weekends, how about how many have outpatient weekend office hours for echo? So again, just not many. Okay. Okay.
For office hours or outpatient echo hours?
Outpatient echo hours. Okay. Okay, well that's interesting. Point of care echo, we didn't really talk about, although it really fits into here as we talk about sort of when we talk about that value equation, and I think Linda mentioned this morning, many of these cases might be able to be done with point of care. Do you want to talk about it all?
Yeah. So just remember this, when you're doing inpatient care, it's going to be DRG based. So you do 1 echo, you do 100 echoes. There's no technical component there. There's a professional component, but there's no technical component. So just imagine you could answer the question well with handheld echo or something like that and use that resource on an outpatient where you're actually getting paid. Kind of makes sense. So, this issue about, this sort of drive, we all do it. We're all doing these inpatient echoes because they're ordered, but yet if you really think about what the opportunity cost is for that machine and that sonographer, we've really got it upside down. So it's just something to keep in mind.
What about home care? A lot of our places are going to transitional care models. Is anyone up here or maybe even in the audience using point of care echo on home care visits by your heart failure team or any others? Anyone?
We are not using point of care echoes. Yeah. We are using... I don't know what's the difference between a big echo, a laptop echo, and a point of care echo. So we're using the laptop. The laptop.
And so you have sonographers going to the homes, or are these nurses that are trained?
No,
sonographers. Anyone else using out in the field for heart failure patients or others? I think you're going to see that as a growing trend in the future. And then the other point, population health, which we really didn't talk much about. When you're managing large, when you've got a large number of primary care patients that need to be managed, and all those primary care docs hear that murmur, maybe a click, they're not sure, they order that rule-out mitral valve prolapse. point of care echo, all you need is one or two views, and you know whether or not there's mitral valve prolapse. And I would think that that's a place where we can screen some of these medical homes, in that accountable care organization where we'll start to see some value to the point of care. Did you have another comment, Jeff?
No, I was just going to repeat the quote that I put in the talk about the future's already here. It's just unevenly distributed. I mean, weekend hours, home health, echo, all this stuff, we're all going to be doing this, right? It makes sense. It's patient-centric. It's better care. It's just that we're all in environments where it just hasn't we just haven't gotten there yet in terms of the immediacy and the need, but it inherently makes sense.
And we haven't figured out how to reward the people who are going to be doing these things. And so the hospital networks need to be creative to make it. Again, we talked about worker satisfaction, both sonographer and physician satisfaction.
And Mike, I think this American Society of Echo has to take the lead on focused echo. So if you're going into the primary care, do you have to do a 45-minute echo because there was a murmur, or can you just say, it needs some backup from the society or to say that standardization that if you go in there and yes, it may be under a limited 2D code, but that these are the 5 things you need to do, and then IAC needs to endorse it because they are all a part of the audit, and you get audited by IAC and then you say you didn't do this, and this, which is not required. So the society and the IAC need to take the lead because that is the future and it's here.
And then one last point of care question to Michael. So the rules for reimbursement for a transthoracic, an 07 or an 08 code or whatever, it's certain sort of image protocol, it's documentation of the images, and it's storage of the images, right, which we can on some machines do and can't on some machines. Reimbursement for these things, would you bill an 07 code for a point of care echo if you had a specific indication for it?
If you did all of those things, yeah, I would. I think the danger with the smaller pieces of equipment in the physician office setting, and obviously most of us now are working in hospital outpatient department settings, not physician office settings, but if you're in a physician office setting, then you're operating under the physician fee schedule, and that's where the rut comes into valuing physician work, practice expense, and malpractice expense. Well, a big component of the practice expense is the machine itself. And I think that CMS and the RUC are well aware that a lot of these physician office studies are being done with very small machines that basically don't support the practice expense that supports the current valuation. So that's something to think about as we go forward.
I mean, well, at some point that'll be revalued.
At some point it will, and that's always a question that will come up. Aren't you guys really doing these all with laptop machines and not full units? So they're aware of that.
Has your committee considered a new point of care echo code for?
Well, that's certainly under discussion, and I think that's something that will continue to be under discussion for some time. It's something that we would probably have to act on in the next year if we were going to do that for various other reasons.
Okay, we've run out of time, but we have one question in the back, so I'm gonna take that one, and then we'll adjourn the meeting.
Does the microphone? Yes, the microphone works. So Fred Kobe, I'm a cardiac anesthesiologist. One thing that we've started to do at my institution in Boston is actually a tighter collaboration between cardiac anesthesia, where we're all board certified, with the echo lab. So it's not 2 groups, it's 1 group. And that's important from an efficiency standpoint, because then we can divert our resources with respect to cardiology to the echo lab and the outpatient imaging studies. And then you can use my resources because we're already there. We cover the ICU. We can then cover a lot of the inpatient studies. And that actually has helped us as an institution together actually improve our value.
Yeah, it makes a great point that there's no reason for an anesthesia department to buy an echo machine and a cardiology department to buy an echo machine. The hospital, at least on the inpatient side, if the hospital has this fleet of machines, they can be distributed where the need is, and that's probably what we need to do as we look at these new models of efficiency. Since Jeff sort of put this meeting together, I'm going to ask Jeff if you have any last-minute observations or comments. I want to, again, congratulate you on putting together a really great symposium today and really appreciate your efforts.
Oh, no, thanks, Mike. I will go back to the QR-UR thing. Those reports come out in September, so in September we'll find out, September 17, how we did in 16. I would just go home and ask your administrative teams, where do we stand? Do you know what this is? Do we have a process that we're looking at it, et cetera? Because that's the scorecard that is not only for Medicare, but now the insurers. And unless you know how you're keeping score, you don't know how you're going to perform. So I would just encourage that.
Great. If I didn't get to your question, I apologize. We had so many, but please come on up. We'll be happy to field them. Otherwise, we really want to thank you for all attending the session. I really learned a lot. I hope you did too.